Hello, my name is Christine Duncan from Dana-Farber Cancer Institute in Boston Children's Hospital. Thank you for joining me today. Today I'm discussing Defibrotide in children and young adults for Veno-Occlusive Disease. As a brief review of the drug Defibrotide, we know this to be a sodium salt of polydeoxyribonucleotide derived from porcine intestinal mucosa. How this works in VOD is not fully elucidated, but there have been many preclinical studies investigating this. Some of the data that has emerged shows that Defibrotide prevents the activation of the vascular endothelium, protects the endothelium from toxic damage and stress, and can lyse clots that are involved in the pathophysiology of VOD. The drug is approved by the European Medicines Agency and the United States Food and Drug Administration for the treatment of VOD in children, and there are ongoing randomized studies of prophylaxis currently. In regards to prophylaxis, there are no EMA or FDA approved drugs for VOD or SOS prophylaxis, including Defibrotide. The institutional practices of Defibrotide and other VOD prophylaxis agents differ quite significantly, and there is not an accepted standard across centers. However, there has been much investigation of the use of prophylaxis for Defibrotide, including a large meta-analysis of 1,230 patients. In this meta-analysis, which included both pediatric and adult patients, they found an overall mean incidence of 4.7% of VOD in patients who received Defibrotide prophylaxis, compared to 13.7% of those not given Defibrotide prophylaxis. The rates of severe VOD were 0.8% in the Defibrotide receiving patients, with a relative risk of 0.31 compared to no prophylaxis. The largest pediatric VOD prophylaxis trial of Defibrotide was performed by the European group. This was an open-label Phase 3 randomized controlled trial comparing Defibrotide prophylaxis versus no prophylaxis in pediatric patients with at least greater than one risk factor for developing VOD. This trial showed a reduction in VOD at day 30 in the prophylaxis group of 12% versus 20% in those who did not receive prophylaxis. Adverse events were similar between both groups. In regard to treatment, Defibrotide is the only approved medication in the United States and Europe for the indication for the treatment of severe VOD. This is a drug that is administered intravenously every 6 hours over 2 hours, so it's approximately 8 hours of intravenous access time. So for pediatric patients, it is important to think about the access issues ahead of time and whether in a sick patient with VOD who's receiving pain medications, blood product medications, many other things, you need to obtain extra access for Defibrotide. It is possible you do not need to, but this is something that you want to think about ahead of time. The current recommendations are for the drug to be given for 21 days if the symptoms resolve, and for up to 60 days if the symptoms are ongoing. This can lead to questions about what to do for patients whose VOD appears to have resolved or improved significantly before day 21, and perhaps those patients may even be ready for hospital discharge. But the need to continue medication at that time is debated. It is important to remember that while Defibrotide may be a key element to the treatment of pediatric patients with Defibrotide, it is part of an overall package of care that includes fluid and sodium management, in some cases paracentesis and thoracentesis if there is organ compromise, blood product support, a multidisciplinary care including the ICU teams for respiratory, hemodynamic, and potential renal decompensation, and the medication management of a patient. There are multiple observational reports of the use of Defibrotide for pediatric treatment of VOD, compassionate use trials, and treatment trials. These trials, in most cases, support the efficacy of the treatment with Defibrotide in pediatric patients. The figures on the right come from a large compassionate use study which showed superior day 100 survival and time to resolution of VOD in patients given Defibrotide compared to historic controls. The same trial compared the outcomes of children versus adults in the large compassionate use trial. The top line shows the probability of survival in pediatric patients, with a lower line showing the probability of survival in patients greater than 18 years of age. We can see that the survival is superior in the pediatric patients, reported at 65% at day 100 compared to adult patients, where this is reported as 46% at day 100. And so in patients who have similar severity of disease, we see that defibrotide has improved survival in the pediatric patients compared to the adult patients. This holds up in a large combined study of pediatrics and adults with the use of defibrotide for treatment. The primary outcome in this study was the day 100 survival. And when the entire patient population, the survival was 58.9%. This was bolstered by the pediatric population, which was 67.9% compared to the adult population of 47.1%. Also interesting in this trial was that it showed that the earlier initiation of defibrotide was associated with significantly higher survival in pediatric patients. So it's important to think about treating early in the course of this disease. And it is held up across this study that multi-organ dysfunction is an adverse prognostic feature. On the panel to the left, we see the outcomes in pediatric patients compared to adult patients with both allogeneic transplant and autologous transplant. In both patient populations, you see superior survival and outcome in the pediatric patients compared with the adult patients. So in conclusion, pediatric patients have been included in most large randomized trials of defibrotide treatment and the largest randomized prophylaxis study. Data suggests that defibrotide is an effective medication in the prevention and treatment of VOD in children. Survival and VOD resolution is superior in children compared to adult patients in the published trials, and earlier treatment may result in more optimal outcome. There remain many unanswered questions. First, with prophylaxis with defibrotide, who are the optimal patient populations to receive prophylaxis? Do you need to have significant risk factors, or should this be given to all patients, or is there something in between? When should prophylaxis start? Should this start at the start of transplant conditioning? Is there a way to do this before the start of conditioning? And for how long should prophylaxis be given? For treatment, there remain similar questions about the duration of therapy. Is a total of 21 days needed? Is that too short? What should be done for patients who are improving? What should be done for patients who are not improving? These are all questions that remain unanswered. And also, are there optimal combination therapies? As I've mentioned, defibrotide is only one part of an entire care package of a child with VOD. What are the optimal partners for VOD treatment along with defibrotide? A hope for a future study is whether an enteral formulation is possible. This may ease some of the issues in regard to medication administration and intravenous access, as well as the possibility for starting the medication prior to a hospital admission, though there is no data to support this practice at this time, or allowing patients to continue medication when they're approaching a hospital discharge. And finally, how do we refine and develop personalized screening methods and treatments for children with VOD based on their individual risk factors and clinical presentations? Thank you very much for joining this module. I appreciate your time and attention.